capable of doing certain things?
Well, we use the PAR. Okay, question is about, I think, risk with exertion. Well, we use the PAR-Q. It's part of our intake form. PAR-Q is developed by the American College of Sports Medicine. It asks about cardiopulmonary risk factors with exertion. And if there are any, then of course we need to get clearance before we train people. We don't do a tremendous amount of heavy exertion in our clinic. I leave that for the athletic development people. But I do see heart patients. I do see cardio patients. I have a woman that came in to see me recently as an example who's a chronic pain patient, fibromyalgia, and was having bypass surgery. She was really in a panic because she was worried her fibromyalgia was going to rage out of control if she had to become too immobilized, because she knew that she needed to maintain certain level of activity. So we did prehab with her, and she hit the ground running post-operatively, but we still have to limit certain things because, of course, there are sutures, there's certain things that she can't be doing, with medicine balls overhead, 2-3 weeks out post-op. I have to wait for clearance. Another question?
For me, this is a lot of new information. And how would we, if we wanted to see it again, how would we get exposure to that?
Okay.
Again?
Rephrase that.
Where could I see it again? Maybe like based on, say, you want to wake up the posterior element, right?
Yeah.
Where could I see what you just showed me again?
Okay. All right. So the question is.
Can I add to that?
Yeah.
Is there maybe an algorithm? So this person has this issue, so we look here, 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 and if they don't pass this test, then we go back here. But if they do and they progress,
okay.
Is there a sort of algorithm for that as well?
All right. So questions really is that dovetail with what you're thinking? Okay. Or are you also asking about what other seminars?
I'm asking that. Where could I see it again? Type it again?
Okay.
Right?
Okay. All right. So two related things. Where can you pick this up again, and what other resources are there out there that can reinforce it? I think the first thing is to see Professor McGill. I mean, that has to be the course that's number one on anybody's list. Gray Cook is right up there. You can come back and see me. I'll be in Alexandria in January. I'll be in New York City before that in October. Come to Copenhagen if you want in September. That would be a lot of fun. You can check my blog for where I am when. I don't know where I'm going. And McGill, you can go to McGill's website. It's in the bibliography are the major websites to look at. You can email me if you have any questions. Professor McGill is teaching in different places from time to time. I wouldn't miss him. And I would plan on seeing him more than once. Of course, the DNS work is very fundamental and foundational, so come out to Arizona if you want to. As far as your question about the algorithms, a lot of this stuff is described in Rehab of the Spine. Okay, we have clinical algorithms and atlases. There's a section in Rehab of the Spine that goes over the regional approach, where there are atlases. Also in the lumbar stability chapter, there are that you'll see, for instance, the bird dog, and you'll see side plank, and there's 2 pages on each with pictures, and it talks about troubleshooting. Then we flip it over in the regional section. We go by test. So the stability chapter goes by exercise. In the regional section, like in lumbar spine, it goes by test. So you'd have failed Sorensen endurance or failed side plank endurance or failed curl up. And it would tell you what to stretch and what to strengthen and what the beginning exercises would be and what the progressions would be. So that's all there. And you'll see some of that brought up to date in the functional training handbook or brought into the new arena of more modern functional training.
You have to open the books for them to work, not just put them on your shelf?
Well, don't read them, but browse at them. There are certainly references. But also Gray Cook has done a good job, as has Greg Rose, at creating algorithms. They call them breakouts in terms of the troubleshooting. When this is positive, look at this. And that's something that you'll get from not so much the FMS as from the SFMA, um, and also the TPI, Titleist Performance Institute courses of Greg Rose. Watch Greg Rose's Golf Channel show. Has anybody seen Greg Rose on the Golf Channel? Fantastic. I mean, a lot of cutting edge stuff, and he is brilliant. He does a fantastic job. Other questions? Yeah.
Do you have any experience with true effectiveness of supplementation?
Four?
Where you mentioned
Okay.
remove the tissues for things that really get absorbed, really make a noticeable.
Okay. Questions about supplementation and what really works. I'm not an expert. David Seaman is an expert. Jeff Spencer is an expert. I'm really not an expert to speak on those matters. I mean, I give a lot of fish oil to my patients and ginger turmeric and things like that to promote resolution of inflammation. But I would defer to other people. Yeah.
Those lines, I know David Seaman has a website that you can go to, and he talks about the inflammatory process and what he recommends. That's all easy to access. SEAMAN.
Is that right?
Yeah. You remember looking at it, right? Really?
Got a great
Bry?
Is Garmin on your resource list?
No.
Can you tell me something more about that?
Too complicated.
Reverse algorithm, Don Murphy's book.
Donald Murphy, the cervical spine book.
Yeah.
Yeah, Don's a wizard at this stuff.
I think he goes into, for more upper body, shoulder, scapular rhythm.
Yeah, his book is a little old right now. It's focused on the cervical spine. Very good for diagnosis and for overview on some very basic rehab stuff. But he hasn't updated it in quite a while. But I would Medline search Don Murphy because some of his scientific studies are much more current, like the use of flossing techniques for the cervical spine or the lumbar spine, and some of his treatment protocols for nerve root patients.
That leads me to another question. Do you have a protocol in mind for TOS patients?
For thoracic outlet. Okay,
Do your functional...
good question. Thoracic outlet patients. Thoracic outlet patients are typically kind of an outlier group. There's sometimes misdiagnosis, I think. I think we are able to help these so-called TOS patients better now if we appreciate Michael Shacklock's work or David Butler's work about assessment of nerve tension. So looking at the median versus the radial versus the ulnar, and doing the different dynamic nerve tension tests, and then doing a trial of the flossing treatments. Butler has a new book that's like a spiral book, like a little notebook. That's very much a handbook. It's inexpensive. It's small. I think OPTP sells it. We have one copy in my office, and it's fantastic for sifting through some of those differentials. So, David Butler, the co-author of Explain Pain. So you can get that from OPTP. If you have a question about it, again, just email me. Because Butler's other books, his textbooks, The Sensitive Nervous System, don't really break it down as well as this new little handbook does. You know the new one? You've seen it? Yeah, it's like 50 pages or something.
Yeah, and each minute has its own page for the different handouts for patients.
Yeah, there's a lot of self-care. Yeah. Yeah, and you can use it as an assessment. You can use all the self-cares as an assessment. These are sensitive patients, and you go and you run them through the tests, and you see which ones are provocative and which ones aren't. You do the ones that aren't, And then you retest the ones that are. And 9 times out of 10, the ones that were provocative become less provocative. It's simple. The exercises are strange. David's a crazy guy. Okay. Questions? Yeah.
Is there any exercises that is okay to have for the patients that have bleed and do on their own and regenerate pain?
Yes. Okay, so the question is, are there any exercises that are okay for a person to do on their own that are painful? And my answer is yes. Well, if they have stenosis, I wouldn't recommend walking. What would be an example of something where the hurt doesn't equal harm?
Like an ankle injury.
Yeah, early ROMs after like an ankle injury or post-op. Some discomfort obviously is okay. I mean, discomfort's generally okay. If it hurts in the target tissue, not in the joint. The best is when the person comes back and they go, God, that hurts so much. Where do you hurt? Oh, it hurts right here. And they're complaining bitterly. Well, how's your knee? Oh, my knee's fine. But amazing, a lot of people aren't used to working out. They've completely lost their bearings about what normal sensations are like. You know, if you go for a hike and you haven't hiked for a while, the next day, your legs probably buckle when you get out of bed. But you don't think that you've damaged anything. You know you're out of shape. But the best example of an exercise that hurts but doesn't harm is a McKenzie extension exercise for a nerve root patient. They may have mild to moderate back pain, and they may have dysesthesia in their leg. They may not even be very concerned about their dysesthesia, but their dysesthesia is worse in the morning, worse when they bend, and worse when they sit. We may be more concerned about their dysesthesia than they are. They may only be worried about their back. And we give them extension exercises, and it withdraws their dysesthesia, but it's uncomfortable in their back. I would give those extension exercises.
I understand because 85% of low back diagnoses
Yeah.
are toss-up anyway between practitioners. Not really, I think really I'm talking about not really being so wrapped up in giving an appropriate diagnosis, but more or less trying to mostly could be used for deconditioning type
Yeah.
injury. So that's why I was questioning that. And a lot of the exercises you hear, if it's painful, don't do.
Correct.
Maybe I only have your first edition. Maybe I was
No, I mean, that's a good question. And, you're asking, I think, about, how do we get started? How do we create a program for somebody when there's this limitation of diagnosis, when 85% of people, we really can't pinpoint the exact pain generator. And then if the exercise is painful and they're deconditioned, shouldn't we prescribe it anyway? I would say you want to find the path of least resistance. When you have somebody in pain, you want to find the most comfortable thing for them to do, and it should be something that you can audit, and on the audit, it's actually reducing their hallmark sensitivities. So that even if it's a little uncomfortable to do, they see benefit from it. So they're able to create a new conceptual model where, yeah, that's uncomfortable, but that hurt didn't equal harm. Because, God, I couldn't bend forward at all before, and now I can bend forward much better. Yeah.
What do you think of a treadmill test as a functional screen? What think the patient can do?
The question is about using a treadmill test for a functional screen.
Have them walk and analyze their,
Oh, for a gait assessment.
yes,
I don't like it.
because
The treadmill is not normal walking.
they're not just on the regular floor.
Oh, sure. I do gait assessment all the time. Gait assessment is one of the most powerful things, but I'm not going to teach it because it's something that I would refer you to somebody like Robert Lardner, for instance, who's a friend of mine. who studied with Yonda, and he's much better at that than I am. Gait assessment can be made very complicated very quickly. It's very important, but I think it's slippery.
It's just not one of these, and I thought it would be a good addition to this.
Yeah, gait assessment's way too complicated, I think.
It is.
Yeah, to put into the context of a functional movement screen. But I wouldn't ignore it. I mean, we look at our patient's gait. That's one of the most important things. And I'm in airports all the time, so I get to practice.